Hi, good afternoon, everyone. Thank you so much for joining us today for the APAMSA Psych Bootcamp. APAMSA, or the Asian American Medical Student Association, is a national organization with about 170 chapters. We are committed to addressing health disparities and happy health. And one of the things we like to do is organize seminars, boot camps such as these to help you guys succeed in your educational journey. We've had a very successful EM, IM, and surgery bootcamp, and we're excited to have our psychiatry bootcamp today. So this is for you. I'm going to introduce Jess to give some announcements and get started.
Hello, everyone. My name is Jess, and I am one of the alumni directors this year, along with my co-Elise. And we want to welcome you to the 2024 APAMSA Bootcamp Series. Today, we have the Psychiatry Bootcamp featuring 3 of our wonderful residents and fellows, and we have some high-yield topics to cover for you all. We're just past the halfway point of our bootcamp series this year. Please check out our radiology and family medicine bootcamps next weekend if you're interested. If you can't make it, the recordings will be posted to our PAMSA YouTube page as well. And in the chat box, please feel free to ask questions while the presenting resident is speaking. The non-presenting speakers will answer in the chat. Also, if you are an audience member and want to answer a question from up here, please announce your name, school, and year of training. We encourage you to participate and ask questions as well as answer questions. And lastly, this alumni bootcamp series would not be possible without our speakers. So please fill out the feedback form with any feedback and acknowledgements. It would be greatly appreciated. In addition, the national board would love to hear your thoughts about the logistical aspects so that we can help figure out how to improve for next year and what went well this year. And we'll also be emailing out the slides to those who complete the survey. Next, I will pass this off to our amazing speakers.
I don't know if you want to share our slides and we can maybe talk along with our slides. I can start. I don't know if someone wants to share the slides of our bios.
I'll share it.
Yeah.
Second. Everyone seeing it?
Yep, we see it.
All right. So where's start presentation on this here, right? Okay. Here's the agenda, and here are the bios.
Yeah, so I'll start off. I'm Jaclyn. I am a rising PGY5 at Montefiore for Child and Adolescent Psychiatry Fellowship. I'm pretty interested in going into private practice and doing some ketamine infusion therapy, which I've trained in my residency. And outside of work, I do a lot of baking, Pilates, and traveling in New York City.
Hi, everyone. I'm a second-year resident over at MetroHealth, which is affiliated with Case Western. It's over in Cleveland, which is also my hometown. I'm interested in doing adult inpatient. I also would want to be at an academic center. I like to teach, and I also like advocacy, so like being involved in the APA. And I like to plan parties, like to watch movies, and hang out with my friends.
Hi, everyone. Thank you for coming. I'm John. I'm from New Jersey. I did both my medical school and psych residency at NYU, where I'm now 4th year. Next year, I'll be an outpatient attending. And outside of work, I enjoy biking around New York City, and I like photography.
Yeah, so our first topic today is going to be the mental stats exam. You can go to the next slide. So basically, this is our equivalent of the physical exam. And the best way that I've ever heard of how to describe what exactly the mental status exam is basically if you wanted to play this person or you wanted someone else to play this person in a movie, in a play, etc., what would you need to know about them? So you would need to know, how they looked, how they dressed, how they spoke, what they spoke about, etc. And for us, it's important to know that it's specific for that point of time, and it covers a range of mental functions and behaviors. And some can be assessed from, asking them direct questions, but a lot is assessed from informal observation. So then we'll get into it. Next slide, please. So the first part, and all of you guys are probably going to end up in residencies that have different templates and have different parts of the mental status exam written in the template. So I just wanted to talk in generic, general terms. So the first part that I wanted to talk about is appearance and behavior. So on the slide, I've listed several things that you can touch about, but basically it's, how they look, what's their race, their ethnicity, do they look like their own stated age? So at my hospital, we have a lot of severely mentally ill patients. So a lot of people who weren't taking care of themselves and then look a lot older than their stated age. How their grooming is, how their hygiene is, how they are towards you. Are they dismissive? Are they cooperative? Are they alert? Do they have any distinguishing features like a tattoo, piercing, wild colored hair, etc.? And then with behavior comes in, are they agitated? Do they have psychomotor retardation or slowing? Any abnormal movements like tics, tremors? How is their gait? And any like catatonic features that you can assess. Next slide. And then with speech, this is more so how exactly are they talking, not what they're talking about. And so I like to mention rate, tone, rhythm, and volume. So rate how fast they're talking, what type of tone, is it condescending, irritable, how's the rhythm, are they talking loud, are they talking soft, how much are they talking, are they hyperverbal, is there a poverty of speech, are they talking with a pressured way, which the way that I learned it is like putting emphasis on every word. Can you understand the words they're using? Like, is it coherent? Is it mumbled? And is it spontaneous? The next slide. And then thought process. So can you understand how they're moving from topic to topic and or what they're talking about? So, there's different types of associations, which basically is how they're moving from topic to topic. Is it logical? And is it coherent? So with different types of associations, there's tight, which is like how we all talk to each other, where I ask you a question and you answer back at answering that question. And then there's circumstantial, where you kind of talk about something else, come back to the question. So I think of it like a circle. And then tangential, where you're going off on different tangents. You can understand how they're moving from topic to topic, but it's still not relevant necessarily to what you talked about. And then other types of, things to put in thought process is there thought blocking, which basically means they're talking to you and then all of a sudden you notice they stop talking and it looks like something's going on in their head and then they start talking again, which you often see in like psychotic patients where they're having internal stimuli going on in their head and that's what's distracting them. Or are they talking about the same thing over and over again? Or are they perseverating? Then next slide. And then what exactly are they talking about? So how I like to personally divide it up is into 3 categories: perception, delusions, and then safety. So perception meaning how are they going through the world? How are they viewing it? How are they sensing it? So you can have hallucinations in all of your 5 different senses, with the most common being auditory. And with auditory are these voices or these, sounds you're hearing ever telling you to do something specifically. That would be like command, like telling you to go kill yourself. You can also have visual, olfactory, gustatory, meaning like taste. And then there's also illusions where, you might hear ruffling outside and you're thinking, oh, that's some whisper, someone's talking about you. And then there's depersonalization, derealization, which is common in PTSD, where, you know, you're having this out-of-body experience. And then there's all different types of delusions. The most common one being paranoia, where, you know, you feel like people are out to get you, people are trying to harm you. And delusions in general basically means a fixed false belief. So, you know, no matter what other people are telling you, you're always going to believe this. And they can be differentiated into bizarre and non-bizarre, with bizarre meaning things that, you know, can't happen, and non-bizarre meaning things that could happen. So, you know, someone technically could be out to get you. But, you know, there's other things where like people believe they're dying, or a nihilistic type of delusion. And that's not necessarily true. Like they're talking to you, they're clearly alive, but that's, you know, exactly like I said, not true. Next is safety, and we'll get into that a little bit more later. But this goes into, you know, self-harming thoughts, suicidal thoughts with intention, meaning they actually want to act on those thoughts. Do they have a plan of what they would do? Same thing for homicidal thoughts. Do they have intention or a plan? And then I put up there PDW, which is a term we use, at least at my hospital, which refers to passive death wish, where basically, you know, if they were to die, it doesn't really bother them. So if they were to be hit by a train, for example, tomorrow, that would be okay. Or if they went to sleep and never woke up, that would be okay. Next slide. And then mood and affect. So basically, mood is what they're feeling, what they tell you that they feel like, and affect is what you view of them and how they come across to you. So how I do it is, you know, basically I just ask them, how would you describe your mood? And whatever they tell me, I put that in quotes in my notes. Whereas affect is, you know, what you feel like they're going through, or what you feel like they're feeling. Is it congruent to like what they say they're feeling? So for example, I've had patients who like tell me they're doing fine, but they're like crying, clearly sad. Do they go through multiple different emotions in that same interview? So do they have a labile affect that would go into the stability? And how much range are they showing? Are they able to show the full range of emotions? Is it constricted, restricted, blunted, etc.? And is it appropriate to the, you know, what you guys are talking about? So if they're talking about death and all these sad things, but they're smiling and laughing, that's clearly inappropriate. Next slide. And then cognition and sensorium. So this goes into, you know, are they alert and oriented? Are they drowsy? What's their fund of knowledge? So a common question is like, who's the president of the US, or who were the last 5 presidents? Or if they can tell you a recent event. And then there's 3 different types of memory: recall, recent, remote. How I like to say is like recall is more your working memory, recent is more your short-term memory, and remote's more your long-term memory. Next slide. And then judgment and insight. So often in amongst like my medical students, this is some terms that often get confused. So judgment is basically, you know, they can assess the situation and they do acts that are within societal norms. So a common way to test for it is you ask them, if you found a wallet on the ground, what would you do? If they said, you know, I would leave it there, that's not necessarily bad judgment. How many of us are actually going to pick it up and turn it in? But if they said, you know, finders, keepers, losers, weepers, then that's clearly poor judgment. And then insight, it's their awareness of their situation. So most commonly how we see it is, you know, do they feel like they're mentally ill? Then next slide. So now we're gonna, you know, change gears a little bit and talk about safety assessment. Next slide. So what is the purpose of a safety assessment? Basically, you know, you're trying to see what is their risk, trying to see how their risk factors and their protective factors weigh out and which one is more. And if they are having a lot of risk factors, how can you modify them to make sure that they're still safe? Next slide. So how do you start? First, you have to ask them. So I always tell my students that The biggest thing that I really want them to learn is to become comfortable with asking someone directly if they're having suicidal thoughts, if they're having thoughts of wanting to die or kill yourself. That's clearly very uncomfortable, but the more you do it, the easier it will be. And then differentiating, are these active thoughts or are they passive thoughts? Meaning like they want to do something now versus, that passive death wish we were talking about before. Next, is this something that they're constantly having? Or is this a recent change? Or if this was something they were always having, is there anything different about the current situation? So I like to know, how intense are the thoughts? How much are they thinking about this? How much time is spent thinking about this? Have they done anything to, prepare for it? Have they done any gestures? Have they, started putting pills together or started getting weapons, anything like that? Are they able to do something to actually harm themselves? So, I've gotten consults for patients that are quadriplegic, they have no way to move, and they're suicidal, but there's probably no way for them to really try to kill themselves. And then how lethal is their plan? If someone, has the means and their plan is pretty lethal, that's probably going to be more of a riskier assessment. Next slide. So, talking about risk factors, like I said before, is there any recent life stressors, anything different about this time? Did they have a recent breakup? Did they lose their job? Something significant like that. Those are all additional risk factors for suicide. The strongest, most significant risk factor for suicide is a prior attempt, with that significantly increasing the chance of a suicide attempt within a year. It's about 100 times more the general population. Other risk factors include family history, access to guns. These are all things you should be asking. Are they using any substances? If they have a psych diagnosis, are they receiving any treatment? If they are having any chronic medical illnesses, any chronic pain, neurological disorders like stroke, TBI, these are all risk factors. Hopelessness, and you'll often see like patients with anxiety or bipolar disorder or anxiety and depression will have a higher risk of suicide than just unipolar depression. And that goes more into like, the intensity, the impulsivity of their thoughts, and then also going into that hopelessness, any history of trauma. And then I put antidepressants there because, all antidepressants have a black box warning for increasing suicidality amongst a young adult population. And so it's important to make them aware of that. And I've seen multiple patients who've had increased suicidal thoughts on certain medications. And then their occupation. So, physicians are having higher risks or higher rates of suicide, especially after the COVID pandemic. Veterans, if they had military service. And then there's several other risk factors. So like sexual preference, people who identify as part of the LGBTQ community are going to be at higher risk. But there's several more than this, but I just thought these were the big ones. Next slide. And then protective factors. So how is their support system? Do they have many people that they can reach out to, many people around them? Do they have a good family support? Are they good about, having close friends that they can tell what's going on? I actually saw among statistics that pregnancy was a protective factor, but not necessarily always. So it's important to assess their situation. Then religion, so that goes more into the support system. People, will find like Bible groups, church groups, but also they might have a strong belief that because that's something that is against their religion to commit suicide. And then having reasons to live. So, their kids, they have to be there for them. There's no one there for them. So they're not going to kill themselves. Next slide. And then thinking about now you've assessed them, you've thought about the risk factors, you've thought about the protective factors. Now, what do you do? So there's different options. First of all, you want to make sure they're medically stable. If they had a pretty bad suicide attempt, they could have had multiple injuries. They could be, recovering from the overdose, several things. So you want to make sure they're medically stable. Do they need a medical admission? Next is what level of care do they need? So of course, the lowest would be like an outpatient where, you set up their outpatient appointments or make sure they have an outpatient referral. And then a step up from that would be like intensive outpatient or a partial hospitalization program, where basically, you know, they go to groups every day or every other day, similar to being in the hospital, but they're not staying there. And if you, and any of these, if you want to discharge them, you want to make sure that you're asking about guns, asking about any access to any other ways of harming themselves, and making sure that that's all secured. And then the other option is inpatient hospitalization. Next slide. So when thinking about hospitalization, whether or not to do it, you should think about how lethal was this attempt. If it was pretty lethal, that's more leaning towards hospitalization. Were people aware, or were they not as forthcoming with this? Did people, you know, were people surprised to find this out? Did they all of a sudden do this and no one even had any idea? Disappointment that their suicide attempt was not successful. You know, they're not regretful of their actions. They're not glad to be alive. They're not forthcoming with information with you. They don't really discuss safety planning, like who to reach out to. Maybe they're agitated. They have a history of impulsivity. They have severe hopelessness, or maybe they have a psych diagnosis and it's clearly that they're decompensated. And also, what's their social support situation like? If you're not able to reach collateral and not able to confirm various details, or that they have the support system, that's going to make you more lean to hospitalization. Next slide. And then now we're going to talk about agitation. Next slide. So basically what I've seen in my review of the literature and what I've seen on the units is there's different aspects to it. So we're going to delve into each of them. For pharmacotherapy, I'm going to let one of my colleagues talk about that a little bit later, but we're just going to touch on the rest of the guidelines. Next slide. So for de-escalation, I think this is a skill that takes much practice. And I think that this is something that maybe not everyone is used to. But when you're seeing an agitated patient, you should always make sure that, you know, you're thinking of your verbal techniques and your nonverbal techniques. So when it comes to verbal, you want to make sure you're using a soft voice, something not intimidating. You don't want to provoke them. You don't want to make them angrier. You want to make sure that you're concise, that you're talking in small sentences, that's very clear. You want to understand what they exactly want, and you want to make sure you're listening to them. And, you know, at times, you know, you might not agree with what they're saying. Like if they're saying, you know, I want to leave and that's why they're so agitated and you clearly can't discharge them, you can come to some agreement that might not necessarily be the agreement that they wanted. And it's important to set clear limits and explain what's going to happen and offer choices and try to make it in a positive way. But of course, remember to ensure everyone's safety. So there's different patients that have different, you know, escalations. And so certain patients, you might not even get to this point, but you hope that you're able to. And so let's say you want to make sure that you're respecting their personal space. You want to make sure you have good eye contact with them, that your body language is also not intimidating, that you're coming off with an empathetic attitude and you're patient with them. And I think this is important to, you know, always practice and always make sure that you're understanding like where they're coming from, because there's probably a good reason why they're agitated. Next slide. And then medical evaluation. So I think this was something that I wasn't really aware of before residency, how so many medical issues could cause agitation, and several of them can be life-threatening. So it's important to get them a good medical clearance, rule out a lot of these first. And so, for example, you know, trauma, infection, respiratory issues like hypoxia, cardiovascular issues like shock, metabolic issues like encephalopathy, neurological issues like stroke, tumor, seizure, and there's so many more, but these are just the ones that I thought I would highlight today. And that's why it's really important to get the medical clearance labs, do a good medical evaluation, to get an EKG, in some cases to get a CT head if this was totally out of the norm for them. And it's important to rule this all out before thinking of a psych issue. Next slide. So then you're thinking about it, you've ruled this all out. Now you're thinking, okay, is this possibly a psychiatric condition? Are they decompensated? Are they psychotic? They're hearing the voices so loud and that's why they're so upset. Or is this a personality issue? So, we like to think about this in a way like, are they antisocial? Are they borderline? Is this why they're acting out? Is it more like behavioral that's why they're acting out? Or is it more their psychiatric decompensation? And thinking about what would their psych diagnosis be? Do they have a past history of that? And all of this goes into the specific medications you choose for treating their agitation, or even what the treatment is for their agitation. Next slide. And then let's say all of that didn't work and the medications didn't work and there's still a huge risk. So as a last resort, you might have to order restraints or seclusion. But thinking about this, thinking about like just having to experience that can elevate the risk of injury to the patient or the staff and the psychological trauma that goes through that for the patient. Now, this is different at different hospitals in different states, what exactly the criteria is or the protocol for restraints and seclusion. But sometimes it's necessary. And like, for example, at my hospital, this is for like a 4-hour period, and the physician has to assess them right when they're put into restraints and seclusion. The nurse can order it and put them in it, but still the physician has to assess them. So I think it's really important that once you guys start residency to make sure that you guys know what the protocols are at your specific hospital. And to also think about, the other aspects to it, like the psychological trauma and how it should be used as a last resort. Next slide. Okay, thank you.
All right, so I'll be taking over and talking about PRN medications. Appreciate you guys all joining us on a random Sunday before residency even begins to learn about how to best prepare for, for your start in internship. And so this is more of like a very brief, like high yield kind of situation, which I wish I kind of had before I started residency, just to have a better grasp on like what medications, doses, things that I can give in various setting between the ED, inpatient, or even the outpatient side, which you guys will all have exposure to. Next slide. So yeah, so Pooja and I have some overlaps with the agitation, topic, and a couple of times you guys will probably be asked to arrive on scene or be paged about a patient getting angry or agitated, and you kind of have to dictate what to do, what to order, and many times you'll be the only person that has to be in charge or oversee, what medications or interventions you want to make. Next slide. We're going to go through this very briefly, but the codes are very different per hospital. The last hospital I was at, it was code M. The current hospital I'm at, it's code Panda. So definitely know which code it is and how to actually get security on board when you do have a patient who's agitated. I want to re-stress the priority of de-escalating the situation. I can't stress how many times offering Oreos or a sandwich has actually de-escalated the situation in the ED, so that we wouldn't have to give IM medications or restraints. So sometimes you just got to ask and see what usually helps with the patient. If the patient has been there before, what's worked really well with, calming them down or knowing their triggers and having a nurse or behavioral staff approach the patient in a manner without like security, because sometimes security in itself can actually escalate the situation further. And you'll definitely build comfort with knowing how to de-escalate the situation. When you've gone through a couple of cases, you want to prioritize the safety of yourself, your staff, your med students. It can get pretty dangerous when patients are very agitated or even in a psychotic phase. They don't know sometimes, or they're not maybe intentionally trying to hurt someone, and it does happen. So really understanding your safety, understanding your exits, never block yourself inside the room between, like don't have, yourself cornered in a room where the patient's like closer to the door than you are. PRN meds I will talk about at the next slide. And then the big thing about physical hold and restraints, there's 4-point, which is the arms and the legs, and 5-point is the upper one that's holding the chest down. That's not available in every single hospital's ED setting. So I would just confirm what your hospital has and how they kind of manage restraints in general if they don't have that. And then Pooja kind of went into the medical reasons, substance, medication. So evaluating exactly why the patient is agitated can be very helpful for any sort of like future occurrences and addressing that. Next slide. Okay, so this is a very brief kind of like high yield PRN medications that you guys are all probably going to be very comfortable with. We use a lot of, combination cocktails. There's 5 and 2, which is 5 Haldol, 2 Ativan. There's 5-250 with some patients who require more of a chemical restraint. So that would be like 5-250 or B52 in some hospitals. 2 and 2 is another combination, 2 Ativan, 2 Risperdal that we give for, acute crises. Other options is Zyprexa, 5 or 10 milligrams. Usually you would start at a lower dose. Zyprexa is great and Haldol is great because you can basically give it as an IM, and that will work a lot faster for some patients who are acutely psychotic or in a very like agitated or aggressive state. And sometimes you can give one antipsychotic medication and then reevaluate later on. In specifically developmental disorders in younger kids, I actually stick with Thorazine. That's something that I've learned to use a lot more now that I'm in my child and adolescent training. So if you're in an ED, I would definitely consider for at least like autism patients or any other developmental disorders, starting with 25 milligrams of Thorazine. I usually start with 25 IM or double that for oral medications. And that's something that when you develop more comfort with what medications you prefer, you can definitely stick with that. The other big thing is understanding what the patient's standing medications are. So if my patient is already on standing Risperdal when they come into the hospital, I might just give them another dose or an earlier dose of their standing medication so that I'm not giving them multiple different medications in one day. And I think this chart's really important to sort of see, your typical dose, max dose that you would give, and then when you would actually repeat the medication. Sometimes you might get some pushback from ancillary staff members to give more medication or give something, 10 minutes after the first round. A lot of it is actually, kind of playing the waiting game and making sure you're not having any more triggers around a patient and then really letting the medication kick in before you give them another IM injection. So this is a pretty important slide as a high yield. Next slide. Okay, so these are some considerations for every single, at this point when you're giving medications, is you definitely want to check allergies first. Some patients will straight up say that they're allergic to Haldol, so you have to, switch it up. Maybe you can give Zyprexa instead. You want to monitor vitals, especially when you're giving medications. Face-to-face is what we consider basically an in-person documentation that a physician or any sort of psychiatrist needs to be present for these medications and afterwards to make sure the patient is not having any acute like side effects. You want to get an EKG. You want to make sure that the QTC is below 500. A lot of these medications can increase the QTC, so we want to monitor for that. And because we sometimes do use benzos, I did put in a relative potency chart here, which is very important. I kind of wish I had this with me when I was going through residency because you'll know that every medication has different kind of like potency. So here, the 0.5 of Xanax is the same as 1 milligram of Ativan, meaning Xanax is kind of like 2 times stronger than Ativan. And that kind of will give you an idea of, how you can sort of, give the correct medication and not oversedate a patient. Really important thing is you never want to give IM Ativan and IM Zyprexa together. If there's anything that I can highlight in my section of medications is you never want to give IM Ativan and IM Zyprexa together. That's a big red alert because it actually increases the risk of excess sedation and respiratory depression. If for whatever reason a patient gets IM Ativan and you decide that you want to give IM Zyprexa, you should definitely wait 1 to 2 hours before you give these medications because of the high risk. Next slide. It's okay to take a pause and debrief the situation. So after you go through an acute crisis situation where a patient maybe is held down and you have to give an injection, it's okay to check in on each other, or check in on yourself. If anyone gets hurt, you want to follow up with them, and that actually helps build, I think, the morality of the team a lot more than if you just kind of move on and address the different patient situation. So I actually we started a debrief initiative in the middle of my residency, and that actually led to I think just building up our morale and making sure that we all were heard and validated, and if there's anything that went wrong, kind of just addressing that before we, take on the next like crisis situation. So this is something that I encourage you guys to either start or try to do when you have these situations in your own programs. Next slide. And the big thing is clarifying your protocol. So every hospital, every program, they have their own versions of seclusion notes, restraint notes, the way to document the medications given, specific times that you have to put the orders in. Everything is very particular to the program. I've worked at 3 different hospitals now, and I can say the procedures are very different for each one. So, during your orientation, if you're going to be in the emergency setting or inpatient unit, definitely clarify what you need to do, because a lot of hospitals do get kind of like docked down points if they don't do this a certain way. Next slide. So other common PRN meds, again, this is more of like a high yield. So we just discussed agitation. For anxiety, I tend to do the same with evaluating their current standing medications. If a patient is already on, a medication like Lyrica or gabapentin or Seroquel, I typically might give them a PRN dose, a smaller dose, or I would give their standing medication a little bit earlier to sort of address their anxiety. I am not a fan of giving benzos out typically. I know that sometimes we do still use it for panic attacks, and I might give a very low dose of Xanax, like 0.25 milligrams, or I might give something for if a patient has claustrophobia and needs to go into like an imaging machine, I'll give a very low dose of benzo. But typically, there's been a sort of pattern and trend towards more of like antihistamines, Vistaril or hydroxyzine, which is the same medication, Benadryl, and low dose antipsychotics also work sometimes. So Seroquel, I might give 25 to 50 milligrams, and that's what's helpful for our patients. So sleep is another topic that I'm going to talk about in terms of PRNs. There's a lot of different options. Next slide. Yep. So let's talk sleep now. Many different settings, many different considerations. I've at this point worked in an outpatient setting for adults and children, emergency department, inpatient, and CL. A lot of it is getting much more detail and information on what the sleep issue is. Is this something that's more acute versus chronic? Is this related to substance use, substance withdrawal, medical issues? Is it more psychiatric in nature, so agitation, delirium, sundowning? It really helps to know what's going on, because if it's not a pure sleep issue, which a lot of people don't just have pure insomnia, it's more maybe something else related to like pain or medical issues. You want to address the underlying issue as well on top of the sleep. Next slide. So the sleep hygiene that I kind of go through is pretty much a thing that I try to stress both in the hospital and outside of the hospital, but it helps for patients to try to keep the same time of like sleeping, making sure there's no like activating activities around them, keeping things quiet, dark, relaxing. A lot of my CL patients, I've actually advocated to have to get earplugs in our hospital, and that's actually been really helpful with them even going to sleep, because they have so much disruption amongst the staff and amongst the floor. Avoiding caffeine is a big thing, and I also go through this chart on the bottom right with the different like patients I have who are younger in terms of like how much sleep they should be getting when they're telling me that 4 to 6 hours is enough for them. I try to reorient them in terms of like what I'm kind of pushing for. And then reducing fluid intakes and even medication administration. Sometimes there's like nursing orders for 10 or 11 p.m. And I definitely will try to have them cluster medications and any sort of blood draw the same time. That way there's less interruptions with the patients. Next slide. So this is actually the preventative measure for the delirium pathway at CHOP, and I go through the first half with a lot of my patients who struggle with sleep in terms of controlling light, noise, not engaging in anything activating before sleep, clustering the care, so clustering any sort of nursing involvement to just 2 or 3 times a day. It's very hard, but if a patient is very sick and they're asking for like help with sleep, I usually speak with the nursing staff, because I can give as much medication as I want for sleep, but if they are continuously being interrupted or there's a lot of noise around them, it's not going to be super helpful. So when I explain that to the patients, their families, and the nursing staff, usually that helps prioritize like clustering care around nighttime. Next slide. Okay, so if you guys want to screenshot this is pretty much my PRN meds that I stick with. There are other medications you can use, but these are the main ones that I use, especially with like outpatient or even CL patients. I just do over-the-counter melatonin. If they are not already on a very high dose of melatonin, which a lot of patients are on, I typically just do 1 to 3 milligrams, and I give it hours before they have to go to sleep. So usually 7 p.m. is when I would start giving it, and I would ask them to start to close the blinds, go into a more like dark and less activating activity. We give a lot of Visceral and Benadryl, primarily Visceral, for adult and children patients, and I'll start at 25 and go to 50 as needed. Standing medications like SSRIs and SNRIs can be activating versus deactivating. They increase the amount of serotonin available in the brain, but they also increase the availability of norepinephrine, which plays a huge role in attention, arousal, and alertness. So sometimes if, patients are saying that a medication makes them sleepier or activating, I would actually make whatever medication they feel activating, I would put it in the morning. And then whatever's deactivating, making them more tired, I would put at evening. And so you can actually, adjust these medications once daily, either for the morning or nighttime, depending on the effects on the patients. It's very individual. If it's anxiety based, I actually stick with these medications. Gabapentin, I'll start with 200 or 300 milligrams once at night. If it works well, you can always, there's a lot of room to go up with gabapentin. So it's a medication that I do enjoy using. Buspar is a medication that some physicians will argue is like candy. It works for some patients, it doesn't work for other patients, but I start with 7.5 at bedtime. Remeron is a great medication that we actually give as an antiemetic. Remeron's also really great for weight gain, and also helps a lot of elderly patients go to bed and also increase their appetite. So I usually start at 7.5, and I'll increase it by 7.5 every couple of days, depending on how they respond. Seroquel is another medication that I also like, that I use for anxiety and insomnia. But I'll start pretty low with 25 to 50 milligrams. If it's depression based, I typically start with trazodone, 25 to 50 milligrams. Doxepin is another one, 3 to 6 milligrams. And this is a little bit more like niche, but suvorexant, Belsomra, I've had some good cases where I did 10 milligrams on my patients, and it worked really well. So I added it into the slide, even though it's not as common. Last resort, absolutely, is benzos and Ambien. I really don't use this at all. I wouldn't start the medication, but some of my patients are on it chronically, and so sometimes I end up starting it if they fail out of multiple other medications. But this is sort of my guidelines with like PRN sleep meds that I use on the outpatient and inpatient level. Next slide. Okay, so a couple of things with these medications. We typically, look at different. We typically want to make sure that we're not causing more side effects than the benefits of giving these medications. So the main thing I'm going to talk about in this section is acute dystonia. Next slide. Mechanism of EPS is sometimes when we give medications that are basically causing a high blockade of D2 receptors in the NS pathway. It leads to this imbalance between acetylcholine activity and dopamine activity. Next slide. So under the umbrella of EPS, we're looking at these 4 primary symptoms: pseudoparkinsonism, acute dystonia, akathisia, and tardive dyskinesia. Interesting thing is that sometimes with the sleep and insomnia, a lot of patients actually will have akathisia, restless legs, and that's actually one thing that we will kind of address in the treatment of insomnia if it's related to restlessness and restless leg syndrome. The big thing here is acute dystonia, because this can be a life-threatening situation where if you have laryngeal dystonia, that's actually going to make it very difficult for your patients to breathe or talk or even move their neck area. Next slide. And this is something that I added from AMBOSS, AMBOSS. It's another kind of like test prep like platform, but they have some different visuals on here in terms of what acute dystonia can look like. It can be your neck, your tongue protrusion, which is very common, oculogyric crisis. The interesting thing with acute dystonia is it can actually affect your entire body. It can affect your limbs, your torso, it can give you really, awkward posture. So it's important to look not just in the facial area, but your whole body. And this also kind of shows you the timeline of when these symptoms arise. So I've actually had a lot of CL pages to evaluate a patient after we started a medication or increase a dose on an antipsychotic medication to see if the patient actually was presenting with acute dystonia. Next slide. Yep. So this is a picture of, this guy with a very strange posture. It includes his neck, his extremities, his torso, and this is something that I would be pretty concerned about. Usually these are involuntary muscle contractions in this case, and like I said, it's due to the imbalance between the dopaminergic and cholinergic levels in your body. Typically, when you get a page about this, you want to go and test for range of motion, breathing, swallowing, speech. If anything has had an acute change, I would be pretty concerned. You want to check for vaccination history and blood tests just to make sure this isn't due to electrolyte deficiencies like calcium and magnesium, hyperventilation, and you want to also rule out tetanus as well as Wilson's disease. This is potentially life-threatening because if this happens and affects the laryngeal area, it can be hard to breathe for the patient, and that would be an acute crisis. So usually I give IV benztropine. I'll start with 1 to 2 milligrams IV benztropine, and then I would give 1 to 2 milligrams BID for about a week after I diagnose someone with acute dystonia. But this is a pretty concerning and high yield situation. Next slide. Yep, and I'll pass it over to John.
All right, thank you, Jaclyn. Almost done, everyone. Second the shout out for coming out on a Sunday afternoon to prepare for residency. Kudos to you all, and I'll try to keep my part quick when possible. I'll be talking about consults and CL psychiatry, as well as some general pearls about residency at the end. Starting with consults, though, the first CL attending I ever worked with told me that a consult is like a sandwich. It starts and ends with the team. I thought it was a memorable analogy. And seeing as some of you might be taking CL called PGY1, as is the case at some programs, an appropriate place for us to start too. So what's meant by this is generally when CL psychiatry is being asked to see the patient, that request isn't coming from the patient, it's coming from the team. So your first engagement will start with a conversation with the team where you will be working with them to understand what their request is and if there's any meaning behind the request, as sometimes what teams request us to help with might not be what we end up actually helping them with from a psychiatric perspective. So usually that takes place over the phone, although maybe it could be in person, that'd be great. And, Epic chat, pages, Epic orders are sometimes ways that CL psychiatry is contacted, but those should not substitute for a verbal conversation with the team where you can understand what their request is and how CL psychiatry can help. So I'll be going through this with the first ever CL case that I saw as a resident, which was this one, an elderly woman who was post-op day 4 after this pancreatectomy, and the primary team called saying that she seemed depressed. And the way that the patient was described, which you should always ask, by the way, since sometimes providers will say depressed, manic, psychotic, and be applying those words very broadly, you should ask them to clarify what they're observing about the patient. And what this team observed was that the patient didn't seem as bright and wasn't talking as much as she was before the surgery. So this initial conversation you have with the team can be very valuable to prepare yourself for this patient that you're about to see. And so everyone has their own style. Some people might like to chat with the team for a while and have a long conversation. Some people might prefer to keep it quick and just do chart review. The consultation itself might also be more complicated, or it could be a very simple request that can be summed up quickly over the phone. But even if the request is simple, generally, my style is I like to ask them initially about 3 things to prepare myself before going in to see the patient. The first is safety. Safety always comes first. And this refers to both agitation towards the team, but also if the patient is at any risk of harm towards themselves, if they have any SI, if they do, whether or not they've been placed on a one-to-one, if they should. that can be decided rather quickly, even before seeing the patient, and that can matter a lot to the safety of the patient. I also ask about behavior, so that's related. I'd like to know if the patient is agitated, to know if that's something I can expect, getting myself into. But also I like to ask if the patient has generally been accepting the treatment being offered by the team. And what I'm asking there and getting a sense of is, are the patient and the team aligned, or are they in disagreement about something? If the patient is unhappy about something or unsatisfied about something, usually that's relevant in some way to the consult. And the third thing is the treatment plan. What's going to be happening to this patient that I'm about to see, either later that day, and also where they're going to end up once their care is done. Sometimes the treatment team might be hoping that psychiatry will take the patient. And if that's the case, that's an important thing to know, as that will be one area where the CL team can be greatly involved in determining the disposition of the patient. Also, before you see the patient, of course, you're going to be able to do a lot of chart review since this patient's already in the hospital. And it's great form to ask other members of the team about how the patient's doing. The team doesn't stop at the MDs, and sometimes the RNs or the other support staff in the hospital might have an even better idea of what the patient's behavior has been like, how they've been acting towards the team, or when they're not being observed by the MD team. So this patient, when I went in to see her, it didn't last very long. She was, again, this elderly woman lying in bed, ignoring me. And when I tried to get her attention, she told me to get out. So already I'm starting to think that she might be having post-op delirium. And if you find yourself in that situation soon, even when the patient's not engaging with you, if you think they're delirious, there are still a few things you can try while you're in the room with them. One is, of course, to try to offer some reassurance. You try to reorient them, assess their orientation, try to see if the reason they're agitated is because they're confused about what's going on. And also ask if they're concerned that someone's hurting them, get a sense of whether or not they're paranoid, if there's a psychotic process going on. And sometimes calling the patient's family member and having them on speakerphone can be very helpful for them to hear that familiar voice. That certainly helped me in a couple cases of delirium. So I've tried to do some of these things now at this point. The patient's now saying the nurses are hurting her, not answering the orientation questions, not paying much attention to me in general, still telling me to get away. Call the daughter. Daughter says that she's never been confused like this before. So starting to think that this is an acute process, not reflecting any underlying psychotic or neurodegenerative thing happening. And valuable information from the nurses. She's been trying to get out of her room. She's been looking through the trash. All things that would not necessarily describe someone who's just depressed, which through the primary team's initial consult request was how they framed the case to me. Rather than depression, it seems to be that this is delirium based on the fluctuation of the mental status, the fact that she's hyperactive sometimes and lethargic at others, and the other things we've observed from the patient in the room. And also from chart review, going through the chart, found some of this stuff. She's had a high white blood cell count, hypoxic recently. Okay, so you've arrived at your formulation of what's going on. The main piece of the consult is what you're providing to the team, and that's the plan, the psychiatric plan. Here's the general recipe that I use in any CL plan. I think about these 5 things and how they apply to the patient that I'm seeing. Again, safety first. Is there anything going on that's unsafe from a psychiatric perspective? Any additional psychiatric workup that can help us with the differential? Any med recs that we have from the psych team, any non-pharmacological recommendations that we have for the team, and then finally, any collateral contacts, and what is this patient's dispo? If the treatment team wants them to go to psych, do we agree or not? What do we think would be the best placement for this patient from the psychiatric perspective? Okay, so for this patient, here are the things that we we did in the plan. So considering a one-to-one for the agitation PRN Rex, as per what we just went over earlier in the presentation. We agreed with the primary team's workup that they were doing to assess for the causes of delirium. Delirium precautions. Don't underestimate some of the non-pharmacological recommendations that we can make. It's been so many times that I'll walk into a patient's room, the patient's delirious, and it's nighttime, but the lights are on bright, the TV's on max volume, the curtains are closed. All these things are not helping with reorientation of the patient and regulation of their sleep-wake cycle, which are two of the most important things to address in treating delirium. Getting family involved, consolidating interventions so the patient's not being woken up too many times overnight, getting them into a chair during the day, again, regulating their sleep-wake cycle and making improvements to their sleep hygiene whenever you can have a substantial effect in treating delirium. And then one cool thing about CL psychiatry is often you can do a lot of psychoeducation for families. So a big piece of what CL psychiatry, our team, provided in this case was talking to the daughter and helping to reassure her about what we think was going on, that delirium is common post-op and that it's an acute process that resolves and gets better. So again, going back to the sandwich analogy, it starts with the team and it ends with the team. So in giving your plan to the team, it's good form to touch base about it again, verbally, over the phone or in person, so that you can collaborate, tell each other how the case is going, answer any questions they may have. Oftentimes, unfortunately, CL consults end with just tossing the plan into the note and hoping the primary team reads it. But ideally, it's better to have everyone touch base verbally so that there can be a dialogue about the plan and collaboration around it. Next, I'll go over capacity consults, which is another very common consult that CL psychiatry receives, and is one that, at least for me entering residency, that felt very high stakes and potentially risky. It gave me a lot of anxiety to think about determining whether or not a patient has capacity. So we'll go over it now. So their capacity consult question might start with something like saying, we're not sure if this patient has capacity, but it should not end there. That shouldn't be the entire question. You should always be asking, what is the decision that's being made? Because decision-making capacity, as you might remember, is not a global property that can just be assigned to a patient that they have or don't have capacity. Decision-making capacity is always specific to the decision that's being offered and the time that it's being offered, because decision-making capacity can change even throughout a patient's clinical course. In fact, skipping ahead to the last bullet point, one helpful thing that CL psychiatry can do is determine if the patient has impaired decision-making capacity, can it be restored? Is it due to some underlying untreated psychiatric condition, like psychosis, mania, or is the patient perhaps intoxicated or in withdrawal? Can we assist in the treatment for that and ultimately restore the patient's decision-making capacity? So understanding what's the decision that's being offered. Also, what's the urgency of the decision? What happens if the patient refuses? Is their life at stake? Your bar for determining whether or not the patient has decision-making capacity can be set accordingly. And what I mean by that is, if a patient is refusing an intervention that's an emergency life-saving surgery that's low risk, you better set your bar very high for deeming them to have capacity to refuse that procedure, because it's a very high stakes procedure, as opposed to something like an elective procedure or a procedure that has a high risk and an unclear benefit. You might be more willing to consider the patient's refusal of that procedure to be reasonable. Here are the Applebaum criteria for determining whether or not a patient has decision-making capacity. So we'll go through it one by one. One is the patient should be communicating a choice, and that choice should be consistent and it should be clear. So if they're changing their mind back and forth due to some disorganized thought process, that is not consistent enough for determining whether or not they have capacity to make that choice. Can the patient understand the relevant information? This one's kind of self-explanatory. Can they understand what's the surgery being offered? What is the medication being offered? What does it do? Appreciating the situation and its consequences. So it's one thing to understand what a surgery is, what a medication is that's being offered. And it's another thing to say that those procedures apply to them. So the patient should be able to say, I have this illness. I have heart failure. Here's what would happen if I accept the procedure, and here's what would happen if I refuse it. Understanding that this will affect their life and the different things that are at stake if they accept or refuse the procedure or the intervention. And finally, reasoning. Are they able to manipulate all those factors that we've discussed in a way that is that makes sense, that is logical and sound? So sometimes hidden in a request to determine whether or not a patient has decision-making capacity could be some other wishes from the primary team for psychiatry to help them make the decision if the patient has impaired decision-making capacity. Now, the proper route for that would be to follow the surrogacy, find a surrogate decision maker, and that does not ultimately fall onto the CL psychiatry team. In fact, it is the primary team that has the care of the patient in their hands at the end of the day. Similarly, the team might have all sorts of legal questions, ethical questions. Would it be ethical to sedate this patient with psychiatric medications to administer the intervention that they don't have capacity to accept or refuse? And while we could help with those questions, ultimately, we are a psychiatric team, not a legal or ethics team that can soundly determine these aspects of the case either. So sometimes part of answering the consult is knowing what we can and cannot assist the team with when it comes to these complicated decisions. So here's the first capacity consult that I ever saw as a PGY2. At my program, we take CL called PGY2. It was a 40-year-old male who was brought in from prison. He had a chart history of schizoaffective disorder, but what he was coming in for was a leg fracture that he had in a fight, and he was refusing the operation. And he was being pretty agitated towards the surgery team, yelling, screaming at them, not really participating in the informed consent process. So importantly, as CL psychiatry, we've got to ask the team, what's at stake? What's going to happen if he doesn't get the procedure? Is his life at stake? And their answer was, no, not really. It's not emergent, but it'd be kind of bad if he waited a while and got the procedure later. The risk of infection would go up. It probably wouldn't heal as well. Now, when you go in and assess if the patient can understand this information, it can often be helpful to have the team with you, because at the end of the day, they're the ones that understand best what the procedure is that's being offered. And they can provide input on the risks and benefits and everything that's at stake for the patient. So this patient initially, kind of like the other patient, didn't last very long, said, "Get away from me." And that's unfortunately something that you might want to get used to hearing in inpatient and CL psychiatry. Oftentimes patients are not happy to see us, but that doesn't mean we don't try. So we figured out that he's hungry, that no one was listening to his complaints. So after giving him some food, after sitting down, hearing him out, hearing what he was upset about, it became very clear quickly to me that actually his mental status exam was pretty appropriate. No psychosis, mania, substance intoxication or withdrawal. And that after a lot of patients and a long interview, he was able to provide a lot of the criteria when we assess for decision-making capacity to refuse the surgery. So he was able to say that he had the fracture. He was able to say that the team was offering the surgery to fix it, which could help him walk, but that the risks were really unbearable for him. His grandma died of blood clots, and he said to me, that would not be the way I want to go. And that he was willing to tolerate the alternative to try to let the wound heal on its own, He wasn't having that much pain. He was okay with a plan for it to kind of hurt when he walks around, and he was okay taking that on versus going in for the surgery. And he even tossed in that if it seemed infected, that he would come right back or ask to be brought right back. So despite it not feeling great, not being what the team wanted, we let him refuse the surgery. And tolerating that uncertainty is a big adjustment that we as doctors might have to make in some cases when patients and teams are not aligned on what they might want. Importantly, we determined that his initial not meeting criteria to have decision-making capacity was probably just due to him being irritable and frustrated in the moment and not an actual inability to manipulate all the information. So even though there wasn't an underlying acute psychiatric issue happening here, we as CL Psychiatry can still be helpful in these situations. Sometimes surgeons don't have the time or unfortunately the patience to talk to their patients and sit down with them and hear out what's happening to cause the patient to be unsatisfied or to not participate in conversations about their care. So I'm going to switch gears for this last section here. Up until now, we've been talking about clinical care for patients and what that's going to be like in residency. But now we're going to switch to talking about you all as doctors and some of the feelings that you might experience during residency. That's a big part of the adjustment after all. And in some ways, this is also kind of going to be like a little psychotherapy review or preview of a couple of concepts relating to psychotherapy. The first one, I've just chosen two things to go over that I think are important things to consider when thinking about the adjustment to residency. One is dialectical thinking, which, as you may know, comes from DBT, one of the psychotherapies we offer. Dialectical thinking is the ability to hold within oneself two seemingly opposing or contradictory views. So two things that seem like they can't go together can be held together. And in DBT, the core dialectic, to take a quick tangent, in DBT, the core dialectic that patients work on is holding together, accepting themselves as who they are, and working on changing themselves. For people who have very black and white thinking and are unable to hold both those ideas together, both of those things can feel very scary. What do you mean I have to accept myself? That means things aren't going to change? Or what do you mean I have to change myself? That means I'm right now who I am is unacceptable. And a large part of DBT is working on integrating those two ideas to hold them together. That's why some modules of DBT are mindfulness-based and present-focused, and others are skills-focused and change-based, like interpersonal effectiveness, distress tolerance, and so on. So I'll skip ahead and come back to the other one. Here are some dialectics that I felt were at times difficult to hold for me as a beginning doctor. There are going to be some days you hate your job. I hate to break it to you, but there will be. And it's important to remember that the job you hate on some days can still be the same job you love on other days. Sometimes when you get sucked into the heat of the moment, you can get swept away into feelings of, oh my gosh, I hate this so much. Did I make a mistake? Is this not what I love after all? Is this not the right job for me? And in zooming back out and holding this dialectic, we can integrate the good and the bad object into the same object. Same idea with like how people often refer to medicine as a passion or a calling and juxtapose it to being a job. It doesn't have to just be one or the other. It can be both on the same day. On some days, it can be just a job for you. And on some days, it can be something that you're really passionate about. And the days that it just feels like a job and you hate it, don't take away from the times when you do like it and enjoy it. Easy for me to say, but also, in my opinion, easy to forget when you're in the thick of it during the stress of intern year. And the last point about self-advocacy versus gratitude, I'll share some experiences I had intern year getting involved with the residency union at my program to protest changes happening to our program, to our call schedule, that were making us all unhappy. And some messaging that we received from the program as part of their response was, you got to be grateful for what you have. You're asking for too much. You should accept and appreciate the things you have in this residency program. And really, that's kind of a false dichotomy too. These two ideas seem to be opposed, but you can hold them together as well. You can advocate for yourself and advocate for things to be better and be appreciative and grateful for what you have without feeling too guilty about it. I hope that was a helpful application to how DBT ideas can be applied to our lives. The next thing I wanted to go over is an idea from psychodynamic psychotherapy. So different modality now. And as a refresher, psychodynamic psychotherapy, one of the main ideas of it is that there's an unconscious mind. And sometimes our emotions can be expressed without us being totally aware of what's happening. It's unconscious. Projective identification is a defense. When I was a med student, I had no idea what this was. I thought I understood projection. I actually didn't, but I'll go over it now. And my understanding of it now is that it's a disavowed affect that gets projected into an other who then introjects the projection. So let's start with just projection, actually. So if I'm talking to Sam and Sam is mad at me, but that affect is very unbearable for Sam, Sam will project it onto me, and Sam will say, you're mad at me. Meanwhile, I feel fine. That's projection. Sam is projecting anger onto me. Now, the difference with projective identification is Sam is saying, you're mad at me. But now for me, maybe Sam reminds me of someone from my life or stirs up something in me. Maybe Sam reminds me of a previous boss I've had, consciously or unconsciously, and I actually internalize that projection and feel the anger. I feel the anger that Sam is projecting into me, and I might even express that and speak in an angrier tone to Sam and make that projection come true. That's where the projective identification happens. How does this apply to residency? Well, I can think of many times now looking back that I really think it does. And here's a long example. This actually didn't happen to me, it happened to my friend, but I think it still applies. To sum it up, basically on CL psychiatry, the psych resident gets a call from the surgery resident, and the surgery resident is very irritable and makes the psych resident feel defensive. Devaluing towards psych, saying that psych is being unhelpful. The phone call becomes an argument that's unable to be resolved. After that call, the psych resident notices that they feel annoyed and angry, but also ineffective and ashamed. And that affect is interesting to notice. Where did it come from? Probably from the surgeons. Surgeons often have bad days. They have a stressful job after all. So perhaps some of that affect is projection and projective identification. And it might start at the surgery resident. It might even start up at the attending. So maybe, if you will, entertain the possibility that cases are stressful that day. The attending surgeon is in a procedure that doesn't go well. And unconsciously, they might feel afraid at what the outcome is. They might feel ashamed at how it's gone, and pass that affect into their surgical resident by devaluing them, as it says here. You better get this patient off the service by the end of the day. Then making that surgery resident feel afraid and ashamed. That surgery resident then passes the affect into the psychiatry resident. All this happening largely unconsciously. But I think this happens more often than you might think. Residency is frustrating. And a lot of time, especially on CL psychiatry, will be spent dealing not just with frustrated patients, but with frustrated teams and team members. And having an understanding of how these affects get passed around the hospital helps to not take it so personally and to understand what's behind some of the conflicts behind teams and why a resident might make you feel angry or ashamed or afraid about something. Helps to get ahead of the problem before that emotion then takes you over. And I think that these ideas can be applied to some of the many challenges that you can expect intern year, adjusting to the teams, always good to ask for help and take care of your own physical and mental health. And the last point I want to end on is a personal plug to be in psychotherapy during residency if you can. And I can think of 3 good reasons for that. One is that life's hard. It's helpful to be in psychotherapy for that. But 2 is we are all becoming psychiatrists. After all, psychotherapy might be a part of the practice that you ultimately offer to patients. And for that reason, it can be helpful to be on the other side and experience the other side of the chair, if you will, and pick up things that might make you a better therapist. And the third reason is, again, consciously or unconsciously, patients might make us feel a certain way. And it's important to be able to examine that, to be able to pay attention to the times when they might remind us of someone from our life or something we've been through. Because if neglected, those feelings could get out of hand and affect the way that we treat patients unconsciously. If a patient reminds you of someone you don't like, well, unconsciously, you might start treating them a little differently. And when that happens, your supervisor, who doesn't know you personally, might not be the right person to go to and debrief this stuff. That's why it's helpful to be in, another reason why it's helpful to be in psychotherapy and have that as a resource as you move through this training that you're all about to embark on. So I'll end it there, and I think we have some time for questions.
Yeah, so we're doing really good on time. So we have about 10 minutes for a pretty free for all open Q&A if anyone has any questions about residency, fellowship, any other transitions, what you should be doing this summer, which is relaxing and enjoying life before residency starts. So if you guys want to either type in the chat or ask any questions here, we're available.
Hi, thanks so much for your time. I had a quick question related to the last point about like hard days. I was wondering how you personally coped with situations in which you might have a difficult day and in which like you might have had actually tough time interacting with like someone on your team, like on the CL team or like in the psych team, and like how you handled those situations. Thanks.
Yeah, I can share in general. That's gonna happen to everyone. And it really helps sometimes to know the mental health resources in your programs. It will vary, but at my adult residency program, we had 3 psychiatrists who actually they were on call for all the residents and fellows in our entire hospital. And so they were people that we could actually text and set up an appointment anytime, either during a weekday or weekend, to debrief certain situations or if we needed, and they would even prescribe medications for any trainees. So we had a pretty good system in place for like when that happens as an extra support system. Um, I think for more immediate situations, sometimes it would actually end up, me bringing someone bringing it up to like a chief resident or even an attending if there's something where you feel like your boundaries are being crossed or something that's bordering maybe like inappropriate. Trying to like figure out like a senior person that you can maybe talk to. I don't know if John or Pooja has that other suggestions.
Yeah, completely agree. And I would add to that that I personally was very grateful for relationships I formed with co-residents to just have others to talk to and commiserate about things that happen. Feelings are always better shared rather than kept to yourself and internalized like this after all. And very common experiences. So it's nice to be able to go through that with a cohort of co-residents if you can.
Yeah, I totally agree with what John and Jaclyn said. I feel like I didn't realize before I started residency, how important it is to have like those relationships with your co-residents. You don't necessarily have to be like best friends with them, but they are the only ones that understand what exactly you're going through. Especially since every hospital system is different, every residency system is different. And so I think that's really awesome. Like, because like even myself, when I have like an issue with like an attending that's consulted me for like, oh, the person looks sad. And then it's like, you know, very rude after that, maybe something like that. It's very useful to me to like be able to rant about it to like my co-residents or like especially the ones that I'm closer to, or even like what John said about like how it comes back to the team. I feel like, you know, at my hospital, like we all rotate consults, but still it's nice to just have that team, like people that you can talk to who are experiencing very similar things or who are on that rotation with you. And I think it's also important to have things outside of the hospital. And I think that's something that we often forget because we get so busy in residency and the hours are so hard, but to make sure you're like continuing those friendships with people like outside of your residency and like having some way like an outlet, like whether it's like art or going to the movies or something that's just totally removed from like psychiatry.
Yep, we still have a few minutes. Any other questions, either if you want to ask or write in the chat?
For the resources, I would say to like clarify with your program what they'll pay for, because a lot of programs will pay for books and might have already paid for different resources. Like for example, my program pays for Board Vitals, which is like a question bank that you can use to help prepare for like Crite or, you know, even your boards. So I think it's good to know what your program's already doing and like what they will fund if they're not already giving you that.
Yeah, I would second just clarifying what your funding looks like, because a lot of programs might actually give you money for technology, books, or anything that you use for your program. And some programs also will pay for conferences. With mine, we basically were reimbursed $800 to $1,000 for every conference that we presented at. And so that incentivized me to basically present at every conference so that I would basically get a free trip to like go explore the APA or ACAP. There's so many different psychotherapy, psychopharmacology, neuropsych conferences out there. So if that's something that's like of interest, I would definitely look them up because you have to submit research projects and posters beforehand.
I think, you know, I just wanted to say like me and John and Jaclyn, I think are really like to do this type of stuff and we could provide like our contact information or at least mine. I won't speak for others. But if you guys want to reach out or had any more questions.
Yeah, second that. I'm happy to be contacted if anyone has any particular questions.
Well, thank you all for listening to us and congratulations again.
Congrats and good luck, everyone.